Welcome back, listeners, to Diversion Insights. My guests today are Abby Migliore and Shannon Opie. They both do work with Intervention Project for Nurses. So, to get us started, first I want to welcome you both. And for those that are not familiar with IPN, tell us, what is the organization's mission all about from a day to day perspective? What does IPN do for nurses, and how did each of you initially get involved in the organization? So, Abby, let's start with you.
Hi, Terry. Thank you so much for having us and really and having this conversation because I think these topics are so imperative to everyone to just learn more about. IPN and Dr. Opie, Shannon Opie is our CEO and I'm our COO of IPN. I have actually been working in with alternative disciplines regulation for over 10 years. Really got into working with nurses and other professionals, healthcare workers who are dealing with substance abuse, mental health issues that may impair their practice, and looking at ways to really help them in that journey because obviously we those practitioners are when they get into those issues, they're not only risking their lives, they may be risking patients' lives. So we want to help them get out of practice, get the help they need that can absolutely save their lives, and then get back into practice because we need those people. We need those practitioners. We need those healthcare workers back in the field. So that's really our mission. It's been my mission for many, many years. And really, I've got into this work by talking to people, hearing their stories, hearing their journeys, hearing what they've gone through, both in active addiction, in recovery, or even going down some of those paths where they're in the misuse areas. And every one of those individuals just stayed with me. And that's really what fuels me working in this is every day helping those professionals. And I know Dr. Opie will talk a little bit more about IPN as well. So
Okay, Shannon.
Sure. Yes. Thanks, Abby, for that. And again, thank you for having us. This is really exciting to be able to speak about these really important topics. So, IPN is an alternative to discipline program, which means that when a nurse, specifically and similar to other healthcare professional impairment programs, when a nurse has a potentially impairing condition like substance use disorder or an impairing psychiatric illness, is potentially endangering patients, then they're able to enter our program if it's recommended that they do so. Um, and they're able to basically receive the help that they need, have their license protected, not have discipline on their license if they're not already known to the board or to the Department of Health here in Florida. And we're able to ensure that the public remains safe while they receive care that they need, and that the nurse obviously is rehabilitated and retained in the profession. And IPN's mission is first to protect the public. Our mission really models right after the Florida Department of Health mission and many other state Department of Health missions and other boards' missions to protect patients and the public first. And so we do want to ensure that people are practicing safely and that nurses are out there practicing safely. We know nurses are first line. They do such critical work, such important work. They lay hands on the sickest of patients, and they are key to any healthcare system from top to bottom. And so we want to ensure that they are safe and that they have support that they need. So if they're struggling with even the beginnings of something like a substance use disorder or some burnout, wellness issues, mental health issues, psychiatric problems, that we're there to provide support and monitoring and education. And I actually got into the field because I'm a nurse practitioner. I started out as just an RN many years ago and was working in psychiatry, acute psychiatry, and detox. And then ended up in a university system here in Florida and started working my way up to gaining my nurse practitioner license and was able to start working in a treatment center as a nurse practitioner treating healthcare professionals who had things like substance use disorders and psychiatric illness. And then eventually this role came open. The former CEO was retiring, and it just kind of worked out perfectly. And I've been the CEO here for several years and really enjoy the work and think that we do something that's extremely important to retain nurses here in the profession.
Okay. So walk us through, if somebody comes into your program, you mentioned education, you mentioned support, like what does the average look like for somebody that enters your program?
So typically, and Abby can certainly add on to this, but typically what happens is we see people when they're usually at their sickest or at kind of their one of their most difficult points. They're usually
Sure.
either self-referred, maybe they're told by their workplace to call IPN or the Intervention Project for Nurses. And that's because they've had a problem at work. Maybe they did cause a potential harm to a patient, or they made a medication error, or they were taking drugs from the workplace. We do see that quite often, drug diversion, or they were showing signs of impairment in the workplace, or had a legal issue related to impairment or due to a psychiatric issue. And so they're told to contact IPN by workplace or by an attorney or a legal issue, or they do have a discipline by the board or the department and they're actually referred to us. So there's multiple means that someone can be referred to IPN. Sometimes people just call and say, hey, I have a problem. I need resources and I need help.
It'd be nice if they all did that.
That would be really great if they did. But typically, I would say about 80% of our referrals are from the workplace, calling and saying this person needs to get in. And they actually still avoid discipline on their license, which is very nice. But once that happens, then the clock kind of starts ticking. And then we, as required mandatory reporters in the state of Florida, have to ensure that that person is not practicing if there's concern for safety issues. So we ask them to voluntarily refrain from practice for a period of time until they're evaluated by a professional, like a healthcare professional, an MD that focuses in on things like psychiatry and substance use disorders, and can make a determination on if that person, if that nurse does suffer from any of those conditions. And then that evaluator or treatment provider would make a recommendation as to if the person needs to be monitored by IPN or if they need treatment, if they need to be in long-term treatment, or if they don't need anything at all, if they don't have a diagnosis, which we do see sometimes. Maybe there was a misunderstanding in the workplace. And so we are just a monitoring program. We do not make the determination if someone has a diagnosis or not, and we do not make treatment recommendations. But that's how it typically starts off, is with someone having a third-party evaluation with an expert of their choosing from a list of evaluators that are actually pre-approved by the Department of Health and by IPN.
Okay, all right, that makes sense. I don't know if you interact much with the referring managers that are referring them in, but I'm curious, what is the most common misconception that you hear from nurse managers or other healthcare professionals about impaired practice or substance use disorders or diversion or mental health even?
Abby, did you want to?
with? Yeah.
Yeah, and one of the things I was just going to add on, thank you, Dr. Opie, and everyone, but one of the things I was going to add on is I'm also a nurse and got my master's in nursing for longer than I'm going to admit on a recording. And also I'm the president of the National Organization of Alternative Programs, or NOAP. So one of the things we look at, not only Dr. Opie and I, but also we look at Florida, but we all look at nationally as well. So a lot of times we help other programs answer the questions. So alternative discipline programs have been around for decades. So, but before they were around, I believe they started up in the 80s. Before they were around, healthcare workers, what happened is if they got into these issues, they they really, regulatory agencies didn't have a lot of options. You lost your license, right? Or
Mhm.
they continued down these paths, or maybe lost their lives, harmed somebody, things of that nature. So these programs not only developed very, very early on in Florida, which is why it's considered a pioneer program, that it was very, very early. But also across the nation now, a lot of states and programs have these. And so when we talk about misconceptions, it's really interesting to look at that not only from maybe Florida's perspective, but that is something I frequently talk to different states, different programs about. And one of the things that I frequently hear is that the alternative discipline or even the board are kind of the bad guys. They're the ones that are
Mhm.
doing this to the healthcare worker. Where when we look at it, what we really are looking at is these people, the people who are dealing with substance use disorders or problems or diverting from the workplace, already have a problem. They already are in a very dangerous situation, not only for themselves, but really maybe for those people they serve. And I'm going to tell you right now, like I said, I'm a nurse. I think we're all healthcare workers in this. We may have talked about, we all can think of how or why we got into healthcare, right? And most of us got in because we wanted to help people. These individuals don't want to harm people and they don't want to get in trouble with themselves, but they're already in these situations. So the alternative discipline model is to try to give them a path to maintain their licensure and get help. But the misconception
Mhm.
I hear is, oh, the cost, the disciplinary, the stigma, the things like that. And what for IPN, we don't have any cost to be in the program for the IPN. Now, when they go for the resources like to get treatment, evaluations, even drug screens that are part of maybe the things they have to do for the program but are done by outside sources, those do have a cost. And that's a big thing that I would love to see more resources for people to get those, but those are not IPN costs.
Mhm.
So again, the misconception is about like how these programs are more punitive or costing
Mhm.
when in actuality, the costs are not coming from a lot of times the program themselves are the major costs they're talking about. It's the aspects that have to go along with the thing because we have to be able to drug screen, we have to be able to make sure with the monitoring. So
Yeah.
and make sure they are safe to come back to practice, things of that nature. So again, a lot of times even nationally, that's the misconception I hear a lot.
It's interesting. Like I would not think of, I mean, I could see how somebody would think a licensing board was punitive potentially, but alternative to discipline, I mean, that's the whole point is that you're giving them an opportunity to, get help and then potentially go back. And as far as costs, I mean, yeah, I could see depending on how many drug tests and all of that stuff. I guess that's part of the accountability and the ramifications of you got to put some cost into the healing process. Somebody has to pay for that,
It
right?
is. It
Yeah.
is. I mean, and that definitely is one of the biggest things is that we are often seen. We attend every Florida Board of Nursing meeting, and we advocate
Mm,
for our participants or for anyone that may need to be referred to us, and we are frequently um, misconceived as being sort of causing problems for the nurse, causing financial issues or making their lives more difficult when we're really advocating for
yeah.
assisting them to be retained instead of,
Yeah.
like in many states, they would just lose their license, never be able to
Right.
practice again. And we not only want them to keep their license, but we're trying to help their lives too, for them to get the proper treatment, to get the support, the help, the therapy, whatever's recommended by these amazing evaluators and treatment providers that we work with, who have excellent training. And that we want them to be able to succeed in life as well as in their profession. um, and it takes a while for someone in the program sometimes to see that, because there is a cost, just like treating any other disease. It's very costly in America to treat chronic illness, and we see substance addiction and mental health issues as a chronic health condition, and something that needs treatment and monitoring, just like diabetes, heart disease, cancer, and people pay for those things. And those are highly expensive things to treat. And sometimes these things are too, for a period of time. So,
Yeah.
um,
That's fascinating. No wonder facilities, organizations are reticent to report if this is how they're looking at things, right?
mhm.
And we can tell them, if you suspect something, you need to say something, because we want to get to them as soon as possible to help them be successful in their recovery plan or getting help, whatever help it is that they need. But if they extend that once they've been reported, now thinking an alternative to discipline program is the bad guy, it's like, my goodness, no wonder.
Well,
Well,
and
report.
you have to think too. Oh, I'm sorry, Abby, but I was going to say, you have to think too, we're still dealing with a state, really like many parts of the country, that has shortages, right? That has problems with retention anyways in nursing.
Yeah.
And so when we're talking about removing someone from the workplace for a period of time where they need to get an evaluation, that can take some time to get an appointment, to get that assessment done, to get the report back, and they're out of work during that time. And then maybe they need to get treatment 30 days, 60 days, 90 days if it's very severe, maybe even just a couple weeks. It just depends per person if they even need treatment. And then a period of monitoring, and they have to leave for drug testing at periods of time, or special accommodations start coming into play in the workplace. There are a lot of hesitations on the employer sometimes to understand why would I want to refer when I can just kind of keep this person going kind of at the bare minimum. And it really is unfortunate, and we saw a big drop off of referrals, really specifically during the COVID pandemic, because of course nurses were needed in droves all over the country. And just like Abby was saying, we heard from programs from the entire country that saw referrals drop and continue to drop, where a lot of them haven't bounced back yet, even since that time, because of nurses still being needed, and people not reporting as much, not being as ready to report, because they just need to keep them in the workplace. They need people to be able to look after patients. It's really unfortunate.
Right.
yeah, and
Abby, go ahead.
oh yeah, sorry. I was going to say the other thing about that, this I think is really important to kind of look at with employers as well, is sometimes remember that when people are dealing with these substance use disorder issues, this might be some of the worst times of their lives. And again, substance does not just touch their professional side. They can be in legal trouble, obviously financial, things like that. So, sometimes when they're venting at work or to their employers, or have to leave, or have to set up to have a drug screen that day or something like that, that they may talk about what they're going through, legal costs, all these kind of things. And sometimes that all gets wrapped up with it sounding like it's all from the alternative discipline program.
Sure.
They may say, I have this much thousands of dollars of fines. Well, it might be legal, it might be something else, nothing to do with things, but as they're talking about the alternative and all the things they do. So sometimes the employer may get a perception that thing. And again, a lot of times when people start the program, they really are unhappy about being in the program, or they may be upset about that what they have to do, because they've been trying for so long to cover these illnesses. That's part of the illness. And then what I've talked to people about later on, either at the end of their monitoring, after their monitoring, or even once they really get into solid recovery, is I'll have these conversations with people all the time so many over the years. And they'll say, I thought you guys were the devil. I thought you were ruining my lives. I thought you were the worst people in the world. And now I realized you saved it. You
Yeah.
saved my life. And that is the core and parcel of what we do. Is the goal is to save lives, protect the public, make sure their lives are protected, safe, good standards of care, and also back to that nurse, because again, these are life-threatening diseases.
Yeah. What would you say to people that really do not think healthcare professionals should come back to work in a position of, let's say that there was impairment, substance use disorder, mental illness is a different category from a medication use perspective, access. But for those that were found impaired or did have an SUD of some sort, to come back into the workplace and handle meds. I've talked to people that are very much, nope, I would never want that person treating me. What do you say to that? Do you see, you could say, well, I'm throwing numbers out. 85% of our people go back and are successful. Well, what about the 15% that didn't and could have harmed someone? So just speak to that a little bit.
Yeah, that's always a huge hot button topic, right? Definitely for IPN, but also nationally. And we've spoken about this at conferences and on the national scale and in the state of Florida. And we deal with it all the time in IPN. And that's just stigma, right? Like it's definitely a lot of stigma and concern, certainly, and a need for education, more education. I think it's an opportunity for education for the public as well as for healthcare facilities that are, rehiring, some of these providers, these nurses. But we have so many safety checks in place now to try to assist these nurses who did, potentially cause harm, or tamper with medications in the workplace. We know that having higher access to drugs is one of the reasons why people take the drugs from the workplace, and that we have drug diversion. That's why we see it in different fields of healthcare professionals, in things like anesthesia and pharmacy, in with physicians, with especially in operating rooms, ERs, ICUs, and then of course obviously our nurses. And so we get very good recommendations from our evaluators and treatment providers for things like if there are specific drugs of choice like opioids, opiates, maybe the person needs to be on an opioid blocker, like a naltrexone or Vivitrol, injectable monthly, that would prevent them from having effects of taking opioids. Or maybe they need to have restrictions of things like passing controlled substances for a period of time while being monitored. And we do that with many of our participants, if that's what's recommended. If they have perhaps substances of choice that they can't take a blockade for, like benzodiazepines or stimulants, something of that nature. So we have those things in place. We have work site monitors in place. We have support groups. We have, medication treatment providers in place. We actually have a safety net around these nurses that the general working population of nurses don't have. They actually have a stronger support network,
Sure.
and measures in place that encourage them and protect them from things like medications, to therapy, to monitoring in the workplace, to drug testing, and beyond that, and other restrictions, maybe restrictions for even certain settings that they can work in that the rest of the nursing population doesn't have. So I would say that those nurses are actually set up to be even safer, with having those restrictions in place. Of course, they do have the history, so I can see the hesitation. And some facilities will not hire people who
Mhm.
have that history. And
Right.
again, that's where we try to come in, and like Abby is so excellent at educating at these facilities, talking about things like stigma and talking about things like diversion and that kind of thing, and what we do with our program and our nurses to assist them after that, or even to prevent something like that um,
Mhm.
in the first place. So,
Okay.
so that we can break down that stigma.
Yeah, and the only the thing I'll add to that is two things. Recovery is possible. The most amazing
Mhm.
nurses, the most amazing professionals you talk to sometimes have had substance abuse problems. And I'll also say this is not new for nursing. Florence Nightingale, look at her notes sometimes about her use of opiates with things. So
Mhm.
again, she was one of the first acknowledged people who nurses who took opiates from the workplace. Again, this is not a new phenomenon for nursing. We and the most amazing nurses have had maybe problems and got help. So recovery is possible. We've talked to these nurses who've gone on to with the most illustrious, wonderful careers. And even you talk about other professions, you talk about these people, and these most amazing people have had substance abuse problems in the past. So why would we discount healthcare from having these amazing people get back into it and really do the amazing things we know they can once they get through
Mhm.
this and get into that recovery space?
Okay. I want to talk now about a study that was done in 2022, I believe. The purpose of the study was to, I found this fascinating, one, that people would answer honestly, and two, some of the numbers. The purpose of the study was to generate a population-based prevalence estimates for substance use and related problems, including substance use disease among registered nurses. So here are some of the findings from this study. 5.7% reported illicit drug use in the past year. 9.9% reported prescription type drug misuse. 18% screened positive for substance use problems, and 1/3 of these for full substance use disorders. To me, those are some pretty high numbers. Which do you think any of these numbers should be driving policy more in hospitals? I mean, if you know that this is happening, should it affect anything that we do around policy?
Yeah, I think the answer to that is really all of it. But I really find some very interesting things with these numbers. Not only the prevalence of that, but it was interesting that they pulled out illicit drug use, which they usually do, illicit drug use and prescription
Yep.
misuse. So, as healthcare workers, because healthcare workers A are around it, but also B were trained in the use of prescription drugs, prescription medications, that typically it is a very high prevalence that healthcare workers abuse prescription type medications because of those factors and some others, of course. So it's interesting, like when you said 5.7% with illicit drugs, which obviously, like anyone else, people use illicit drugs in any profession or
Right.
non-professional space.
Mhm.
But it's interesting, it almost doubled. 9.9% talked about the prescription drug use. And so, or misuse. So again, to really be cognizant that the prescription drug use can also be impairing. They can be mood altering, and also nurses tend to abuse those quite a bit more because we feel like we understand them. Um,
Yeah.
that's
I
really
would
kind
just,
of yeah.
yeah, I was going to add, I wonder how they define misuse. If I have a prescription in my medicine cabinet and my sister comes over and says, I've got I'm going in to do the dentist in 3 days and it's killing me. And I'm like, oh, well, here, I have a Percocet, you want to take that. I mean, technically that's misuse as well, but it's not
Right.
an addiction problem, right, that we need to talk about. So I'm curious how they define that too.
Well, it's interesting when you talk about the world of substance use disorders. We look at it really as a time or you know, a category, a big long line, you know, because it can start with over here maybe prescription misuse. So you know, a lot of times when people categorize misuse, is they talk about taking more than prescribed, not for
Sure.
the reasons it was prescribed, maybe that getting it from somebody else, things of that nature that may not denote physical or physiological dependence, or even what they consider a full out addiction, you know, the brain chemistries and things like that. But
Mhm.
obviously that is risky behavior towards substances. So it's more, you know, you're more likely to start taking maybe more and not within those realms of the prescriptions. Up to misuse, to dependence, to full out addiction. So again, people can be on that kind of timeline of or line of that. What they kind of talk about is the misuse of substances up to dependence and addictions and things of that. So I think you're exactly right. When they talk about misuse, it really depends, you know, what they're talking about. That is a big word to a
Mhm.
lot of behaviors, but usually it is denotes some risky behavior with medications.
Yeah.
Well,
Okay.
and I think it's really important to point to the fact that, like, since Abby said it is sort of like a timeline of severity, uh, that there are points where there's an opportunity in some cases, not all, but there's an opportunity to catch this early on and
Mhm.
identify early impairment in the workplace. And we actually, IPN formulated an education that provides CEs that's actually required by state legislation for all nurses to take the CE every other renewal, because it's about identifying impairment in the workplace, and we're talking about early identification of this, even so. You know, maybe someone is coming in appearing hungover, and that can be from a substance. That might not be from alcohol. It could be from taking too many something on the weekend, or you know, partying a little too hard illicitly, or maybe taking too many of their prescription medications before their shift because their back was in pain or something like that. Slurring their words a little bit, not being as sharp, you know, making some slight errors, but nothing really egregious. But there's just enough concern to say, you know, are there patterns here? You know, is there enough concern that we want to start documenting this and start noting it and follow our internal hospital policies first, and start, you know, taking note of these things so we can report it and see what our internal department wants to do, because we have concerns about safety. And some type of, you know, intervening can occur early on, and maybe that person doesn't need IPN monitoring. Maybe they just need some EAP, some therapy, some time out of practice, you know, some education, you know, who knows, medication
Yeah.
changes. But that's why I think these studies and these statistics are important, because it does show kind of that, like, what does misuse even mean, kind of thing. Well, it is kind of like a span. There's a span of severity there, and you know, having one criteria, you know, ASAM criteria. You know, we're talking about mild, moderate, or severe disease, right? Um, if you have a disease, a substance use disorder, it's going to be mild, moderate, or severe. Um, that depends on how many criteria you're meeting, right?
Right.
And so in other professions like pilots or like DOT, if you have one, if you meet one criteria, you're out. We don't want a pilot. We don't want a pilot flying the plane with even one criteria, right? So that's
Right.
very early intervention. So we don't wait for
Right.
the plane to crash. In healthcare, we we don't start intervening or doing things until there's two to three, you know,
Yeah.
until there's a couple, you know, we consider it a mild condition. And so that does raise that question: do we need to change policy about when we're starting that intervening should internal policies look at, how things are dealt with in the workplace?
Yeah. The other statistic in that study was surrounding health hospice nurses and nursing home nurses, which, okay, health hospice, 19% reported
Mhm.
misuse, and in nursing homes, 15.8%. And I feel that these are some of the least supervised settings, so probably way easier to miss.
Mhm.
And then charge nurses, staff nurses and charge nurses had 9 to 12 times the odds of substance use disorder as compared to educators and researchers, which I think makes sense. I mean, you've got exposure, stress, access, maybe all three. Do your referrals bear all this out? Are these the kind of percentages that you're seeing come through for these types of um, specialties, shall we say, where they work?
Yeah, I think they do. And I think, what you also look at with health, home health, hospice, and even nursing homes is the stress as well as those frontline nurses.
Yeah.
Also, maybe they're seeing people at their end of life. We don't take into account vicarious and secondary traumas a lot with nursing. The other thing in that study that I found really interesting is they really looked at the amount of like energy drinks that people were using,
Mhm.
which, I know we don't necessarily categorize that always in the substance use disorder realm, but it's something to kind of look at with stressors, if you don't have energy, if you're not sleeping, if you're things like that. So all those are kind of contributory. We talk about risk factors for maladaptive coping, which substance use can be. And so it kind of all goes hand in hand. The other thing is, yeah, a lot of times home health, hospice, or nursing homes sometimes are considered um, maybe less oversight. But actually, when I working in regulatory, I found that they have a lot of they also report very, very quickly.
Oh,
They do audits of their paper charting quite a bit because they've kind of known these statistics for some time. At least the ones that I've talked to seem to. They do a lot of education about it, and sometimes people who have these issues who've maybe been released from somewhere else and waiting for kind of that legal to catch up go to these because they think that and then they don't. Also in home health, a lot of times you see the same nurse over and you'd be surprised how many times those families report
okay.
things like that. So and actually you think that is a negative, but the quicker somebody can be reported for their misuse or even things like Dr. Opie said earlier, is the quicker the intervention. So maybe the less severe the illness goes along. Maybe we can get them off the path of going down where they get full out, down depends. Or even so people always say when they come in, well, I didn't harm a patient. That should not be the goal. The goal is always to not harm a patient. That shouldn't be your criteria. The fact that there was a risk or you kind of know there was a risk for you harming a patient should be the concern. The whole goal is not to harm a patient. So that shouldn't be oh, I have a problem because I did that. Like
Right.
Dr. Opie said, you don't let the plane crash. So I think those are a lot of what those statistics are telling us as well.
Okay. Let's shift to like the opioid blocking you mentioned, medications and stuff. Is there a difference when somebody's returning to work depending on whether they're on buprenorphine or methadone or, how are these things handled from a safety sensitive role and returning to work? Should there be a difference? Can they all go back? Doesn't matter what they're on? What are your thoughts on that?
Yeah, it's a great question. Again, as the monitoring program, we can't make the recommendation of what someone takes or isn't going to take, or um, what they can or can't do. We do have policies, strict policies and procedures that are reviewed by our Department of Health annually, and that are updated regularly related to all of these topics. But when we're talking in terms of whether, different medications are used for, let's say, opioid blockade, or opioid use disorder, MAT therapy, medication assisted treatment, um, uh, talking like buprenorphine products, or methadone or Vivitrol or naltrexone, injectable naltrexone. Um, we handle these in different ways, and each person's case is individualized, and we do follow the recommendations of the evaluator or treatment provider, whoever is, providing these medications for them. Oftentimes, initially, someone may be refrained from practice for a period of time to show, stability in taking the medication, in dosage and that kind of thing. There are requirements in IPN that if someone's taking a buprenorphine product or methadone or any other controlled substance that could be potentially impairing that they're going to be on for a period of time, that they do have neurocognitive testing to ensure that there is a level of safety to practice at a higher functioning requirements of a nurse, higher cognitive functioning while taking the medication. Things like hand-eye coordination, memory, cognition, just a variety of things that are tested for. Every single person that's on a buprenorphine product, which is a very small percentage actually of our population, is required to do that. So we do require that for buprenorphine. I think we've had maybe 1 to 2 people on methadone, like ever. And we did require testing for that as well, and then worked towards a transition time of that person weaning off of that, and I believe switching to a buprenorphine product in one of those cases, but that was many years ago. And again, these are monitored very closely. We have to receive reports from the treatment providers, from the prescriber. We have to know what dose they're taking. These are reviewed by our medical director, who has a history of being a medical review officer, so he understands toxicology. We add special testing to ensure that they're actually taking the medication and that they're compliant with it. And then when we talk about things like Vivitrol or naltrexone, since this is a full blockade, an opioid blockade, this is actually the preferred treatment for someone with an opioid use disorder. We find the highest levels of success and the easiest return to work, again, because this can oftentimes be used in lieu of having that key restriction or inability to pass medications if they have the opioid use disorder. So that's very helpful. And compliance is not of as much concern because it's a monthly injection and we get documentation of that. And if we don't receive the documentation, then they're refrained from practice until they receive the injection. So that's very helpful.
Is IPN doing some research on that? Can you share what you have discovered? Were there any outcomes that you were surprised in with the
Yeah,
research?
I was actually just about to mention we did a really interesting study a couple years ago, both IPN and our sister program that works with all of the other healthcare professionals and licensed in Florida, PRN, the Professionals Resource Network, for people taking medication assisted treatment for opioid use disorder and chronic pain. So things like buprenorphine, Vivitrol, or naltrexone, and maybe in very few cases methadone. And what we found, one of the key things that I think was really helpful to note was that everybody that was on a buprenorphine product that did the neurocognitive testing had completely normal findings in their neurocognitive status. Nobody had deficits. Everybody did completely fine on their neurocognitive testing. So again, related to that question that you asked earlier, I don't want this person treating me. They've used these drugs in the past, I don't feel safe, that kind of thing. Should they be allowed to return to work? They've stolen opiates in the past or something of that nature. A lot of times they may have these blockades in place or these treatments in place. And we know that their brain is functioning well and they have this other safety piece in place. So that's a big help for the person and and for the public. So I think that's really interesting. And again, the people who fared best as far as things like um, not relapsing, quicker return to work, ease in finding employment were the ones on the injectable naltrexone or Vivitrol. Those are kind
Yeah,
of
and
bigger outcomes.
compliance was a big part of that, right? Because you knew
For sure.
that they
For
were,
sure.
yeah,
Yeah.
getting it.
I haven't really mentioned much about oral naltrexone that does come in a pill form. That can be taken daily. That is sometimes recommended. Some people say they can't tolerate the monthly shot. We really try to stay away from that when possible. Again, we don't make the recommendations, but if they are recommended to take the oral, um, we did study that as well, and we noted that those folks kind of did not do as well as the others in terms of compliance, relapse rate, kind of in every area. And so we know that that is not as effective for, preventing relapse and for protecting the public and the nurse. So,
Okay. Okay.
it's still an option, but it's
Yeah.
not as strong.
Right. We've alluded to this a little bit in our conversation about trying to catch it upstream a little bit earlier, right? I think the system is built more for looking for that smoking gun in behavior or data that may add the icing on the cake with a positive drug test, right? What would a system look like that was more proactive? And what do you think is the honest reason why we don't have it? I'd like to hear from both of you on that. Abby, we'll start with you.
So I think one of the things that would begin with the proactive is kind of exactly what we're doing here, having an open and honest conversation about what it is, what it looks like. And I think really telling people and showing people how prevalent it is, how much people are dealing with this, because a lot of times people push it kind of under the rug until it gets to the point that they can't any longer. And then they're so down that line that they might only, like, the only option is full blown inpatient treatment or something like that. Again, we don't make those recommendations. I've heard somebody in recovery before who talked about, at first they just took away his substance of choice. They got him off the medications or substances he was abusing, but then didn't give any kind of coping mechanisms. And so then they took away his coping, even though it was very, very negative coping. And then he seriously considered suicide. So I think we have to not only look at, when we're talking about these issues, kind of look at some of the underlying things associated with it. Nursing healthcare is very stressful. It can be long hours. We can be around it. So I think, going beyond talking about just a substance use disorder and kind of talking about some of the core underneath. How can we help healthcare workers with coping, with destigmatizing getting help, destigmatizing asking for help early, even maybe before they're getting into substance, but maybe they're, like you talked about, the misuse, and they're getting this misuse because they're using it, because it helps me sleep at night, or it does this. Understanding that some of those are going down those paths or could be going down those paths. So I think destigmatizing it, offering more resources, earlier intervention, and just having that open conversation that it can strike anyone. This is a disease that does not discriminate. We usually think of somebody as low willpower, poor morals that get into substance abuse, and they're not. They are people just like us. They are brains just like us that have become addicted and had these pathways develop.
Yeah. Shannon?
Yeah, I mean, Abby said that perfectly. I completely agree. I think it starts with helping the helper, right? Like we have so much stigma still, which is very sad in this day and age, with the amount of collective trauma we've all experienced, especially with kind of just what's happened in the last several years, with this worldwide pandemic that everybody dealt with, and just kind of just the general daily stressors that we all go through. And then you add in the fact that we're talking about frontline healthcare workers that see death on a daily basis, that see trauma on a daily basis, and they have families to go home to, and kids, and daily life and responsibilities and bills, and are dealing with the difficulties in the economy just like everybody else, and and have all the regular stressors of someone with a non-safety sensitive job, um, who don't have the opportunity to maybe talk about these things openly, because they're supposed to be, the nurse is supposed to be the strong helper, the person that is always caring for someone else, is always helping someone else, and always providing support and listening, and that's naturally just what we do all day long. And so by the end of the day, when we don't have the resources in place, and I think a lot of the barriers, unfortunately, if it's a facility, if it's a hospital system, some of the barriers may be cost to education, time, certainly time constraints, staffing. How do you pull, staff out? Thank goodness for things like these types of platforms, right? Like virtual, so you don't have to pull everyone into a big seminar room and do an all-day conference anymore. Now you can like record an education, a webinar, a seminar, something like that, and make sure that your staff is able to watch it when they have time. But even that still it's time, and that's time and money for the facility, for the staff. It's time away from patient care, and we're dealing with places that are typically short-staffed anyways. And so those are a lot of the barriers, along with just the stigma, and I think just the stressors of trying to coordinate, where to start, how do you start something like this, like a support program in a facility that doesn't really have it. And so that's where education, and support comes in. And that's why we do such a push for, let us provide, resources for you. IPN can be a huge resource. People can call anonymously. HR people can call and just ask questions. Nurses can call anonymously if they just want to ask about themselves. They can just ask, like, what are my resources here? What do I do? A lot of times we direct them to their own EAP or their own HR first, to see what services they have in place. But people don't know what they don't know. And, it's hard to start to get the help and to reduce the stigma, when those resources aren't in place. And so that's
Right.
what we're trying to provide.
Okay, that makes sense. Yeah, and I think a lot of times we think of people with a substance use disorder as not being willing to admit, but I think there's also those that aren't there yet, but they have those risky behaviors of misuse, whatever that may be, and recognizing, ooh, I'm kind of going in the wrong direction here. So let me address it and get the help that I need to make sure it doesn't go any further. Okay, I want to thank you both. And for the listening audience, Abby and Shannon will be returning guests, and we will be discussing on that podcast cannabis. Should facilities enforce a cannabis-free workplace for patient-sensitive roles, even if it's legal in their state? So watch for that podcast or subscribe so you'll get notices when a new podcast is posted. Thank you, Abby and Shannon.
Thank you so much.
Thank you.